Sure. So it's a specialty that entails a complex, big organ. The gut is, as you know, is not a one single organ. It's a combination of several parts and a variety of disorders in each segment or organ within itself. Like, for example, the esophagus or food pipe, which is in the chest,
Yeah.
has got its own disorders compared to the colon, which is the large intestine. It's completely different disorders. Then there are disorders which run throughout the gut.
Okay.
So it's a wide it's a complex organ which has got a quite interesting science behind some of the disorders. In addition to that, there is also an additional component of looking after various organs in the tummy, like pancreas, gallbladder, and liver, of course. So that itself is a big organ itself. So it's a huge organ that's got connections with the whole body and various has got overlap with many other organs actually.
Okay.
On top of that, there was also that charm and attraction of doing endoscopy, which is intervention. So I always had in me to do a bit of surgery. In fact, I wanted to be a surgeon initially.
Right.
But I found gastroenterology to have the right balance between being conservative and invasive at the same time. So it was quite a charming specialty for me.
Brilliant. Well, I think it's very interesting that you say that it gave you a very fine balance between managing conservatively and obviously in some cases where you decide with patients that you have to be invasive. So that's actually the first time that I've heard that from a specialist in any sort of form of manner. Very interesting. They're very valid, I would say. So it is. It's a safer approach as well. Well, thank you very much for that insight. And hopefully it should inspire future gastroenterologists who aspire to become gastroenterologists to see professionals like yourself. Now, would you like to tell the listeners a day in your working life? Describe a day in the life of a gastroenterologist, please, Dr. Zahid, for the ease of our listeners.
So a gastroenterologist would normally be on a general medical rota as well. So essentially, the normal day would involve either looking after a group of inpatients, both having liver and gut disorders.
Sure.
But in addition to that, we might also have general medical patients with more generalized medical conditions, including lung and other disorders. So that's the inpatient bit. The outpatient bit to patients on the outpatient basis involves doing clinics, endoscopy lists, which is similar to surgical theater list. We go in there are about 4, 5, or 6, sometimes more patients as a day case. We do the procedure and they usually go at the same day. Not every gastroenterologist does endoscopy. Similarly, not every gastroenterologist does general medical rota either. Right. So it's kind of a mix and match between various job plans. So as I said, it's a complex specialty. Not every gastroenterologist, even in the same hospital, would have the same job plan or interest. So everyone is different, I suppose. There is no standard sort of day for a gastroenterologist.
Yeah, so it is obviously because of the listeners. It's a busy day, isn't it? Especially if you're doing the medical ward rounds, etc. So it can get quite busy and can get quite hectic as well. So, Dr. Zahid, could you tell our listeners a little bit? I have tried to say my little bit, but obviously it sounds different when it comes from an expert such as yourself. And could you tell the listeners about inflammatory bowel disease and the signs and symptoms associated with it, please?
Yeah, sure. So inflammatory bowel disease, essentially, as the name suggests, refers to inflammation within the bowel. But when we talk inflammatory bowel disease, or IBD in short, as we call it, that refers to specifically a group of disorders which are manifested, basically characterized by autoimmune inflammation of the bowel. So autoimmune meaning that body's own immune system or defense mechanism going a bit haywire and causing inflammation within the bowel against the healthy bowel tissue. So there are two distinct diseases within this umbrella category of IBD, which are ulcerative colitis and Crohn's disease. The two of them have got lots of similarities and differences between them. There are lots of similarities between management and treatment as well to some extent.
Sure.
So essentially, depending on which set of illness you have and which part of the bowel is involved, the symptoms can vary, obviously. So if you talk specifically about ulcerative colitis, as the name suggests, colitis basically means inflammation of the colon or large bowel. So basically, it's an illness specifically or very specific to the large intestine. It doesn't go beyond the large intestine. So large intestine is the lowermost part of the gut. It's about lower sort of 70 odd centimeters of the gut. So the illness often involves the superficial inner lining of the gut of the large bowel and doesn't go beyond the large intestine. The symptoms can be blood in the stools, bloody diarrhea, urgency in going to the toilet, and sometimes cramps before opening the bowels. So these are the usual symptoms. Often they are accompanied, if they are more severe, they are accompanied by weight loss, lack of nutrition, fatigue. And then Crohn's disease, on the other hand, is a more sort of, I can't use the word freelance, but essentially it does involve anywhere from mouth till anus. So essentially, it's an illness that can involve any part of the gut. In fact, in some severe cases, it can go outside the gut too. However, within the Crohn's disease, the most favored sites are end of the small intestine, where it joins the large intestine, large bowel, very common in large bowel, and about 5 to 10% patients with Crohn's disease can have illness even higher up in the stomach and the esophagus. And similarly, 5%, probably a bit more, would have illness around the tail end of the gut of the bowel, which is perianal disease, as we call it. So there are various manifestations of Crohn's. Depending on which part of the gut is involving, the symptoms can vary. But as I said, the most favored site is small bowel. So the symptoms generally would be nausea, sickness, pain, and diarrhea. But generally, blood in the stools is not common unless it's involving the large intestine. So you can imagine, I think, nearly every symptom of the gut can actually be present in the Crohn's disease.
Right, I see. And I suppose anybody that's diagnosed with Crohn's disease and ulcerative colitis, they definitely do go on what some people say a life-changing journey, from my experience of seeing patients. And a lot of patients say to me, why? How is this caused, doctor? How is it that we have contracted the illness? Would you have an answer for those listeners who are affected by this illness?
That's a question we are trying to answer as well as doctors. We are trying to find this answer since the evolution of this disease. I mean, Crohn's disease especially has taken a turn for the worse in past 20, 30 years, despite having new treatments. It's evolved into a more malignant disease, and especially in younger folks who are having it at an earlier age now. So essentially, there is the consensus between the physicians is that there is no one cause for causing inflammatory bowel disease. Okay, there are several factors which contribute to it. Genes definitely play a part. So if you have someone in the family who has got ulcerative colitis, I'm talking about a first degree relative, then your risk of having ulcerative colitis will be, about 25%. The risk of having Crohn's disease is also high if you got someone in the first degree relative in the family. So genes definitely play a part, but there are several other factors like environmental factors. Diet is a major role, especially processed food, benzoates, which are often found in fizzy drinks. So they have a direct correlation with causing this.
Oh, goodness. Okay. This is very interesting because for listeners out there, we've got obviously evidence, which is where you give this advice. And for listeners out there that do send your children to go and get their chicken and chips around the corner and fizzy drinks, it's definitely not advisable to embark upon. So it starts education always starts from a very early age. And Dr. Zayed has said to you as listeners that they're trying to find out what the cause is, but there are some contributory and risk factors, and one of them being, yes, fizzy drinks and the benzoates that are found in that. In the last we've got obviously another 6 minutes till the break, but are there any other factors? So the environment factors, what would you suggest are contributory to inflammatory bowel disease, Dr. Zahid?
Well, there are things that we know and the things that we don't know. So air pollution is one. Weather apparently has got a role somehow. And then there are other environmental factors. So a good population to study would be like a country like Israel, for example, in which we got migrants from all over the world. Right. So the Jews, which are Ashkenazi Jews, mainly from European descent, seem to have higher incidence of IBD. So they take the genes with them, but they also got different diet. So their incidence in Israel is actually higher. But those who are from Arabic origin seems to have much lower incidence, same as Middle East or subcontinent, for example. So essentially, I think there is a pool of genes which travels within families, within generations, but there's also other factors like diets which don't change overnight. Right. There's another factor, urbanization, as we call it, or you see these takeaways going more and more into rural countryside. I suppose it's pretty homogeneous in Western countries, but when we compare it with a country like China, for example, you see that I've been to China recently. Apparently, IBD wasn't actually a very prevalent disease there, but now they've got an endemic of IBD because of takeaways like McDonald's and KFC being rampant there, actually. So that is definitely playing a part, actually. So this urbanization, change in lifestyle, processed food, this is all playing a part, major role, actually.
Wow. So listeners, if you are listening in to the very valuable information, which I'm finding very valuable because I take a lot of what I learn from a lot of the expert colleagues that come onto the show to speak to you as patients in practice. And the thing that I'm learning here today is what is usually we learn in medical school, but we never take this knowledge with us. So your processed foods, your environmental factors, they all do play a very big part. So like we always suggest on every show, please do think about what you are feeding your bodies. And if you've only just tuned in, you are joining Dr. Shabina Asad-Kiyum with consultant gastroenterologist Dr. Ali Zayed, who's very kindly joined us all the way from Scotland. He's a consultant gastroenterologist at the Monklands Hospital in Airdrie in Scotland. And you are tuned to Salaam Radio in Peterborough, 106.2 FM. I know that I have lots of listeners nationally and internationally. And if you'd like to be part of the conversation, please call us on the studio telephone number on 01733 602 133 or text and WhatsApp us on 07745 278 978. I've just had a text come in saying, fantastic show. This is a topic close to my heart from a sister Saima. So thank you very much for all of the information. Thank you very much for your kind comments. We hope to continue to follow the trend of making this an interesting show. And Dr. Zahid, it's very interesting that you have spoken to us about the genetic pool that has been taken to countries amongst Ashkenazi Jews, etc. So is there also, are you also establishing that this condition, inflammatory bowel disease, has a genetic component? Has research established that it is?
Yes, we have actually. We've gone much further in that context. There are, as you know, in the recent past, we've done the Human Genome Project in which we've done the decoding of the whole human DNA. They found several genes which are associated with various illnesses, and we have isolated several hundred which are associated with IBD. But it will probably take a little while before it's actually used commercially. But the genes would actually tell us is what kind of disease pattern one particular patient with IBD is going to have. For example, patients who've got, or families who've got inflammatory bowel disease, we can assess the gene pattern in the newborns or preemptively, and assess as to which kind of disease they are at risk of actually. But I think that's a thing for the future. There are definitely many other factors which are actually contributing to the illness or causation of the illness. Remember, what the consensus is that it's a chain of events in a genetically susceptible person that leads to IBD. So it's without those chain of events or triggering event or priming event, you would not develop IBD. So that event or chain of events needs to happen, and that would involve diet and all that.
Sorry to have to cut you off. We are going to a break. Please, Dr. Zaid, don't go, and join us after the break.
Okay, thank you.
أشهد أن لا إله إلا الله أشهد أن لا إله إلا الله أشهد أن محمدًا رسول الله أشهد أن محمدًا رسول الله حي على الصلاة حي على الصلاة حي على حي على الفلاح الله أكبر الله أكبر لا الله أكبر الله أكبر لا إله إلا الله اللهم صل على محمد وعلى آل محمد كما صليت على إبراهيم وعلى آل إبراهيم وبارك على محمد وعلى آل محمد كما باركت على إبراهيم وعلى آل إبراهيم في العالمين إنك حميد مجيد اللهم رب هذه الدعوة التامة والصلاة القائمة آت محمدا الوسيلة والفضيلة وابعثه مقاما محمودا الذي وعدته اللهم آتنا في الدنيا حسنة وفي الآخرة حسنة وقنا عذاب النار اللهم بك نحيا وبك نموت وإليك المصير رضينا بالله ربا وبالإسلام دينا وبمحمد صلى الله عليه وسلم نبيا ورسولا
بسم الله الرحمن الرحيم لإيلاف قريش إيلافهم رحلة الشتاء والصيف فليعبدوا رب هذا البيت الذي أطعمهم من جوع وآمنهم من خوف.
This is Salaam Radio, Peterborough's Muslim. This is Salaam Radio, Peterborough's Muslim Community Radio, broadcasting on 106.2 FM and online.
Where there's a right, there is no.
Hello, Assalamu alaikum. This is Dr. Shabina Asad Qayyum back on the Body Health and Mind Show on your very own Salaam Radio, Peterborough's only community Muslim radio station, broadcasted on 106.2 FM and online. And we have a very distinguished guest on the show, Dr. Ali Zahid, who is a consultant gastroenterologist at the Monklands Hospital in Airdrie in Scotland. And he has given us an extremely interesting insight on the whole aspect of inflammatory bowel disease. Dr. Ali Zahid, are you still with us?
Yeah, can you hear me?
Yes, I can hear you. It's very kind of you to come back to us again. I think we were having some problems again earlier on, but no worries. We will try and hold on to you for as long as we can up until the end of this show. So, Dr. Ali Zahid, we were talking about the whole sort of environmental factors as well as the genetic factors that can cause inflammatory bowel disease. Did we get to speak a little bit about the symptoms? Because I think the patients, they sort of know about blood in diarrhea. What age group does inflammatory bowel disease affect, Dr. Zahid, if you could let the listeners know?
Primarily, it's an illness of young folks. We expect it to be between 15 to 40. It's more prevalent during this time, 15 to 40 years of age.
Right.
But it can happen at any age. As I mentioned, the disease is evolving actually and becoming more sinister, more malignant these days. And what's happening is we're seeing Crohn's disease at a much earlier stage. The teenage, even younger kids are developing it in a bad way.
Right.
And same is the case in older age. We're falling more and more. So older folks developing it in ages that we were not usually seeing them before. So it can happen at any age, but generally it's a illness of young folks.
Right, okay. And in terms of a patient journey, obviously we would diagnose, well, we don't do the diagnosis. As a general practitioner, I see, say, a 20 to 25-year-old who have come in, they have been describing having blood in their stool as well as severe abdominal pains for the last 4 to 6 weeks. I'm sort of trying to think about nice guidance as well, but they're losing weight and lack of appetite, etc. And we send them to yourselves as colleagues. Could you please tell us what the patient pathway is, what type of investigations they undergo, and the consultations that you have with them?
So generally, by the time when they are referred to us, they've already had at least one consultation with the GPs, had a set of blood tests, a routine blood test, which gives us an idea as to how urgent the things are. So if they're anemic, their blood count is low, and their inflammatory markers in the blood test are high, that's a usual indication that there is an inflammatory process going on somewhere. And if they obviously got bowel issues, then most likely it's coming from the bowel. So there is an urgency to investigate them and come to the bottom of it soon rather than later. So there are two pathways we can follow. If the symptoms are mild, we generally bring them to the clinic and discuss the investigations and management. If their symptoms are quite bad, we refer them straight for an endoscopy, in which we put a flexible camera up the way, going from the tail end of the gut up the way and looking at the inside of the large intestine. Right. And that would give a diagnosis of inflammation of the bowel straight away. This is the best test we can offer.
Okay.
On the other hand, if they're too unwell and rapidly deteriorating, we can even bring them into the hospital and get them admitted. That only happens in about 5 to maybe 10% of the patients, or at the initial presentation. So it's relatively rare scenario. So most of the time, they would have one consultation, would normally be seen in the clinic, in which we assess whether they are, their symptoms are bad enough to require a colonoscopy. Obviously, it's an invasive test. So in young people, a lot of them have got other conditions which have got similar symptoms, barring blood in the stools. They've got very similar symptoms in irritable bowel syndrome, which is a completely benign disease. So in most of the young folks, the main dilemma that we have as physicians is to whether they need an endoscopy or whether they have a benign condition that can be managed conservatively. Most of the time, they have blood in the stool, we do end up requiring either a stool test called calprotectin, which is a sensitive test for screening of the bowel inflammation. And if results are high, then we go to the colonoscopy. If they look if the symptoms look very genuine and debilitating, then we go straight to colonoscopy rather than waiting for calprotectin results.
Okay, right. So I've got a question here actually from a brother Atif, Dr. Zahid, and he asks, does the process of putting a camera hurt, or does it cause any pain, and what preparation is needed beforehand?
It's a very common question, common concern actually from the patients who are having it for the first time, especially in young folks. So procedure is meant to be, not meant to be painful. The procedure generally involves putting a flexible tube with a camera fitted at the end. I generally give them a year as my little finger. That's how thick the gastroscope is, which is the camera from the top end. The colonoscope is slightly thicker than that, actually.
Okay.
So the colon or large bowel is not one straight long tube. It's actually convoluted at places. So we do have to follow the inside. So it's not a straight procedure. But it's, the way we are trained, we give plenty of sedation prior to the procedure and do it in a pain-free manner as best as we can. And majority of the people don't have any issues with pain or discomfort. Prior to the test, obviously, large bowel is the place where normally the undigested food comes and is got rid of. So to visualize the inside of the large bowel, we need to give a bowel preparation, a laxative, a strong laxative to the patients a day before the procedure.
Right.
So they will have about 1 to 2 liters of fluid to drink the afternoon before, so that they are passing clear stools by the time they come for the colonoscopy. And that enables us to visualize the inside in an adequate, satisfactory manner.
Right. And a question that I think I would like to ask on the back of Brother Atif's question is that does this sometimes become problematic for those people that tend to stay chronically constipated, because we do see an increase in the number of people that suffer from chronic constipation? It can make the procedure become inadequate, isn't it?
That's right. It's a bit of a trial and error. Generally, the patients who have got chronic or long-standing constipation, which is very common actually in this part of the world because the hydration status is not the same. We don't drink enough water. We don't have enough fiber in the diet. So constipation is relatively common in this part of the world.
Yeah.
But the laxative, the bowel preparation that we give prior to the procedure is often adequate for most of the people.
Right.
Those who still have poor bowel preparation at the time of colonoscopy, we then give them an extended regime of bowel preparation. So, for example, rather than 1 or 2 sachets, we give them 3 sachets or extended run, and we give them a regular laxative, different form, prior to have actually starting the bowel prep for colonoscopy. So, for example, they can start something like Senecot or Lexido, which is sachets of laxatives prior to a week prior to the actual procedure, and then have those 1 to 2 liters of laxative just the day before. So extended bowel preparation is what they actually need.
Right. Thank you, Dr. Zahid. Now, if you've just tuned into the show, we're having a very, very interesting program here with Dr. Ali Zahid, who is a consultant gastroenterologist all the way in Airdrie in Scotland, and he is giving us his expert advice regarding inflammatory bowel disease, namely ulcerative colitis and Crohn's disease. Now, Dr. Zahid, what you can do, this is back to the listeners, is you can text and WhatsApp, as some of the listeners have, on 07745 278 978, or if you're particularly concerned about this condition, would like to talk a little bit about it, don't hesitate in calling us on 01733 602 133. And before I go to the next question, which has come through, Dr. Zahid, would you like to tell the listeners a little bit about the treatment? So they've had the scope and you've seen something on the camera test, and it looks probably like it's ulcerative colitis. You bring these people back into clinic, and what treatment or what management do they go on, pathway do they go on with yourselves, please?
So at the time of endoscopy, we take biopsies, and that's the key sort of part of the investigations to make final diagnosis. Without the biopsies, it's not possible sometimes to differentiate between an infection, for example, or a drug-induced inflammation and inflammatory bowel disease. So it's important that biopsies are done and an optimal diagnosis made, because it's a lifelong condition. It's not a
Sure.
condition that is a one-off. So we must be confident as physicians that that's the right diagnosis. We
Right.
generally tend not to start treatment before the endoscopy and biopsies, because that can actually change the actual picture. If we start someone on treatment before the endoscopy, then that can give us a misdiagnosis due to some changes which might have resolved by the time. So the initial the treatment all depends on the severity of the disease.
Right.
Uh, if it's mild disease, which is majority of the cases, it's mild to moderate, um, we tend to start them on a drug called mesalazine. So mesalazine is salt, fairly benign drug, very few side effects. It's something I call as aspirin of the gut. Is so commonly used, and it's
Right.
actually useful for more than one reason. Essentially, it's A, is quite benign, doesn't have many side effects. B, is good not just for inflammation of the bowel, but also to prevent bowel cancer and other conditions that we don't know of yet. So it's a good starting drug to control the initial or relatively mild to moderate symptoms. We
Right.
generally start it either in the tablet form or granule form. It comes in different shapes and forms. Um, in patients who've only got inflammation right at the tail end of the gut and not throughout the large bowel, we even tend to give treatment from the tail end directly, influencing the inflammation directly,
Right.
and that may not require any tablets in the longer run. So the initial treatment for most of the patients is mesalazine. If, for example, they've got moderate or severe form of disease, generally we give them a drug like steroids just to control the initial part of inflammation.
Sure.
Often when people hear about steroids, they get a bit frightened
Worried, yes.
to long-term effects like diabetes and hypertension. But we only use steroids for a very limited course of time, a limited course for a limited time, and generally within that time frame, there is less chances of developing any long-term risks or long-term complications associated with steroids. So
Right.
steroids are generally the first line for in controlling the inflammation.
Right.
Often those patients who go on steroids are the ones who also require a drug in the longer run to maintain that remission.
Okay.
So essentially, they've got bad inflammation that requires symptom control and normalization, essentially, and that is steroids can do that initially. But in the long run, they would need a drug which can prevent the inflammation from coming back.
Okay.
Often the word relapsing remitting disease for inflammatory bowel disease. So if we leave once we give them steroids, often patients get better. Majority of the patients get better.
Right.
But when they stop steroids, the symptoms start coming back. So that's what we call as relapsing remitting disease.
Yeah.
So it is to avoid any relapse and further courses of steroids, we need to give them a drug. And then there are several choices. There are about, we didn't used to have many choices, but we now got several drugs that we can use. Quite a number of these drugs are also used in other similar conditions
Yeah.
like rheumatoid arthritis and several other
Yeah.
eye conditions, etc. So these are well tried and tested medications in various conditions.
Okay, well that's brilliant. Obviously, it's been quite informative in terms of the medication pathway. And before we go on to talking, before we do I'm going to answer somebody's question who's just spoken here. That I've recently, Brother Sadiq, he says it's okay to take his name. I've recently been diagnosed with ulcerative colitis. I have been given some steroids as well as the mesalazine. It makes me feel very sick, however. Does that mean that my medication needs to be changed? Because as soon as I stop taking it, I start bleeding again.
It's a bit relatively rare to feel nauseous
Okay.
with both of these drugs. Actually, they are relatively well tolerated,
Sure.
but it could be that he needs a different form of mesalazine,
Right.
uh, and that might be more suited to his body.
Okay.
Steroids, on the other hand, generally don't cause nausea.
Right. Okay.
However, some patients developing reflux symptoms, heartburn, and they require an extra tablet like omeprazole or Zantac just to control the acid reflux symptoms.
Right, I see. So, Brother Sadiq, if that's an answer to your question, that you have said that you are still bleeding when you come off the mesalazine, it makes it. So Dr. Zaid has said that basically it could be that you are feeling nauseous if you aren't on a medication to protect the lining of your stomach that is usually given to patients who embark upon a course of steroids. And there are other ways of giving the mesalazine as well. So in the first instance, I think it's important that you go and see your general practitioner. If you are being followed up in the first instance by your gastroenterologist, then do seek that specialist advice. Now, Dr. Zaid, when we are coming to a person that has had ulcerative colitis, Crohn's disease, inflammatory bowel disease for a very long time and has been on these immunosuppressive drugs that you describe, they've had their fair share of flare-ups. There are some that unfortunately have to be admitted for surgery, isn't it?
Yes, that's right. Especially more common in Crohn's disease.
Okay. Would you like to tell the listeners about what happens to such patients?
Previously, say about 10, 15 years ago, we didn't have many choices in terms of medical therapies, and most of the patients would end, with Crohn's disease especially, would end up requiring their parts of the bowel removed, which is so surgery for Crohn's disease was relatively common up to about a decade ago. But last decade, we've had several groundbreaking drugs like infliximab, Humira, vedolizumab. So these are the drugs which are fairly expensive but very effective drugs, top of the shelf. Essentially, they have got a direct effect on inflammatory pathways and are very effective in controlling the symptoms and disease. So they have in some way changed the path of Crohn's disease, and very few patients after having these drugs actually require surgery. The key thing is to recognize the pattern of disease early. So it's important thing is that if you have got a sort of severe form of disease, then it's important to be under close scrutiny of the gastroenterology team, be in good contact with them. There are often sort of IBD helplines, which some patients generally tend a bit shy to contact, but that's specifically what they're there for, to recognize sick patients and treat their symptoms sooner. Okay. So essentially, if their disease is acting in a severe form, generally they are switched on to strong immunosuppressants like infliximab sooner than later, and that is avoid surgery. Those patients who do unfortunately end up having surgery, there are various forms of surgery which are required for various shapes and forms of inflammatory bowel disease. As I said, most commonly Crohn's disease involves the tail end of the small bowel. So it's very common, especially in young folks, to actually present with small intestinal Crohn's disease. And often the part which is normally narrow anyway. Nature has made this part. The joint between small and large bowel is a bit narrow. And when you have inflammation on top of that, it becomes narrower. So often patients present with intestinal obstruction, sometimes openings or fistulae within that area, which actually requires surgery to fix that and take that part of the bowel. Then, depending on where the illness is, the surgery can vary. In ulcerative colitis, often if the disease is uncontrolled with medicines, no matter how best we're trying to manage this, if the illness is uncontrolled, then they end up requiring surgery. In this scenario, if they're going for surgery in ulcerative colitis, the surgeons would tend to take out the whole of the large intestine and won't leave any disease or any bowel left, irrespective of how much inflamed or which part of the large bowel was inflamed. They will take out the whole of the large bowel away.
Wow. So it's a big undertaking for a patient who unfortunately has reached that stage of the illness and then has to part with their bowel, because they then have to suffer with wearing a bag, essentially, don't they?
Yes, initially. So those who are having surgery for ulcerative colitis especially, if they have their whole of the large bowel removed, they will initially require a bag because the small bowel will be taken out through the skin in the form of a stoma.
Right.
And they will initially require a bag. But often in these days, especially 6 months to a year after, once the whole area is healed, they will rejoin the small intestine with the remnant of the large intestine in a procedure which we call as pouch formation.
Right.
And that's the way in which they won't have a stoma. The normal function will be restored.
Right.
They might be going to the toilet more frequently because they won't have a large intestine,
Yeah.
but they would have control over it, and their normal function is restored.
Okay. Oh, that's wonderful. Well, thank you very much for making the listeners aware of what implications can be. I have another sort of, well, not really a question, but somebody who is known as Adnan. Dr. Zahid, thank you very much for a wonderfully insightful show. I think more people need to be aware of the conditions of ulcerative colitis. I would like to say that I myself have been a sufferer of Crohn's disease. I had to go through surgery, and now I have a pouch. I do, however, suffer from some infection of the pouch known as pouchitis.
That's right.
Yes.
So that's basically a condition which is actually caused by surgery rather than by inflammatory bowel disease alone.
Right.
The reason how it happens is when the whole of the large bowel is taken away, the surgeons a few months after will join the small bowel with the remnant of the large bowel in the form of a pouch. It's called J pouch, it's like a J shape.
Okay.
And what happens is the remnant of the large intestine, or rectum as we call it, is joined directly to the small intestine. This is not an area which is normally exposed to the normal healthy bacteria within the small intestine. But you can imagine that there is nothing in between the two organs. So all the healthy bacteria within the small intestine, which are in billions, are directly exposed, are basically entering into the rectum.
Right.
And they are the ones which cause the internal changes and inflammation. And this is what we call as pouchitis or pouch inflammation.
Right.
The treatment for that is initially at least different from inflammatory bowel disease. We tend to give them antibiotics to get rid of the bacteria. And when we get rid of the bacteria, often the inflammation goes away.
Right. Okay.
Often those patients who develop recurrent inflammation of pouch, they require a probiotic, which is called as VSL.
Right.
So a probiotic would often help them avoid recurrent inflammation of pouch.
Okay, well, very interesting. In fact, the whole show has been very interesting. We only have 3 minutes, and I always say that our time runs out too soon, Dr. Zaid. But I think we have had a wonderful insight into inflammatory bowel disease as a result of your expertise and the knowledge that you have been able to share with us. And I think that here on Salaam Radio, the listeners that have managed to listen in, especially because the station serves the community, they have a good level of knowledge, because often what happens is they feel quite shy of speaking about such issues that they find are quite personal and quite private and quite intimate, actually, openly speaking to health professionals such as GPs. And actually, the service that you're doing is that you are giving the information in such a way that we've already had so many questions of people who are suffering from the illness and at the same time are given a perspective of their position and now can actually say, well, yes, I've heard from Dr. Zaid that I need to call up my local inflammatory bowel disease team if there is a problem, and I need to speak to and go and see my GP if I'm having blood per stool or per rectum, if there's any bleeding per rectum. And what would be your message to any of the listeners, all of the listeners today, in fact, that are listening, who think that they have a bowel problem? Because it's very difficult. I think, a lot of people think going to a doctor, having the relevant examinations makes them feel quite shy and quite embarrassed. What is your message to those listeners today, Dr. Zahid?
Well, straightforward message would be don't be shy, actually. It is definitely private talking about these kind of things. Having investigations for that, like endoscopy, also, it's not the most dignified test, essentially, but it's done in a safe environment by very experienced people. And it's actually required to have a confident diagnosis. and to manage the condition adequately. Often patients are afraid, a bit scared as well to go because of having the fear of the endoscopy.
Yeah.
So don't do that. It's just, that's probably in most of the times we don't end up requiring endoscopy. A lot of bowel issues are fairly benign, and they can mimic conditions like ulcerative colitis. As I mentioned, irritable bowel syndrome is actually much more common due to various reasons, and especially in young folks, than in inflammatory bowel disease. And it's something that your GP or gastroenterology specialist would be able to differentiate even without doing endoscopy.
Yeah. Well, thank you very much, Dr. Zaid. With last few seconds, we will definitely get your expertise back on the show, and thank you very much for joining us today.
Thank you. Thank you for having me.
No worries at all. Thank you. And join us next week on Salaam Radio.